Good day. Discussing the clinical evaluation and diagnosis of pediatric cataract, and I'll be using the following outline. The detailed history, ocular examination, and systemic evaluation are very key in the management of pediatric cataract. Therefore, early clinical evaluation diagnosis with management by an expert is important in the visual outcome of patients. For the history, we start with the biodata, the name, the date of birth, the gender, the race and ethnicity, the weight of the child, and also the occupation of parents and guardian. Patients with pediatric cataract present with one or more of the following complaints. They can present with whitish opacity in the eye, poor vision. The mother can complain that the child is unable to smile back at her. They can also complain of shaky eye, ocular deviation, trauma to the eye, asymmetry of the eyes, or referral from healthcare providers due to identification of lens opacity, poor developmental milestone, or other systemic conditions. They can also present with history of photophobia, poor performance in school, or accidental finding during an eye screening. For the detailed history, we want to know the age at the onset of complaints and the age at diagnosis. This can serve as prognostic indicators in the subsequent management of the patient. We want to find out whether the child is able to move around in an unfamiliar environment. We want to find out history of delayed developmental milestone, and we need to ask specific questions in order to rule out systemic associations. For the medical history, we want to find out the child's general development. We want to know whether there was any recent illness and the mode of treatment, any previous injury to the face or head. We want to find out if there is any systemic disease like diabetes or galactosemia. We want to find out the use of medications, especially prolonged use of corticosteroids. For the obstetric history, the mother's health during pregnancy should be inquired after. We want to rule out touches infection. We ask for history of rash or illness during pregnancy. We want to know whether the mother was exposed to alcohol, tobacco, drug, or ionizing radiation during the pregnancy. We want to know the mode of delivery, whether it was with forceps or cesarean section, whether the delivery was preterm, and even the birth weight of the child. We want to find out if there was any injury to the face or eye during delivery. For the family history, it is important to find out if there was any family history of childhood cataract and how the cataract was managed and the outcome as well. For the examination, we assess the visual function, the ocular alignment and motility, the red reflex, external examination and anterior segment, systemic evaluation, and examination under anesthesia. For the assessment of the visual function, the method to be used will depend on the age and the level of cooperation of the patient. We need to document the visual function, the method that we used, and the level of cooperation, which are very useful in the interpretation and comparisons in subsequent visits. For the assessment of visual function, we use age-appropriate method. For ages 0 to 6 months, we want to know whether the child has the ability to fixate, to maintain fixation and follow light. We want to see whether the child objects to occlusion in one or both eyes. For 6 months to 2 years, we can use hundreds and thousands and others. 2 to 3 years, we can use hair pictures on their symbols and others. For 3 years and above, we can use the Snellish chart or logman and others. Other tests of visual function are fusion and stereo acuity tests of near and far, and glare testing, especially in posterior subcapsular cataract if indicated. For the red reflex, we use it to detect the density and the extent of the opacity in the visual axis. We can use the retinoscope or ophthalmoscope to do this. For the ocular alignment and motility, we do the cover and uncover test, the alternate cover test, which are performed in the primary gaze, at distance, and at near. Risk of strabismus is higher in early onset unilateral cataract. Therefore, strabismus at presentation is an indication that the cataract is long-standing and significant amblyopia is likely to be present. Also, presence of nystagmus is an indication of poor visual prognosis. For the external examination and anterior segment, we look at all the layers of the eyes, starting from the eyelids, we look at the position, we look at the eyelashes. We want to know whether there is sign of blepharitis, tearing, discharge. Conjunctiva, we look out for inflammation. The cornea, we look out for opacity. And the pupil, we check the size, the shape, the symmetry, the reaction to light, and whether there's posterior synechial iridodenensis and others. For external examination anterior segment, we continue with the lens. We look at the morphology of the lens, the position of the opacity, the color, and the density. In unilateral cataract, the fellow eye must be examined to rule out asymmetric bilateral cataract. We can use mobile slit lamp for younger children. Both parents and siblings should also be examined to establish the presence of familial cataract, which may be subtle and unknown to the parents. For systemic evaluation, because many systemic conditions are associated with congenital cataract, such as chromosomal abnormalities, infectious diseases, metabolic disorders, renal disorders, parathyroid disorders, musculoskeletal disorders. A general physical examination is carried out. The child should be examined from head to toe. For examination under anesthesia, we check the intraocular pressure. We need to do the keratometry and the scan in order to determine the IL power that we're going to insert. We examine the two eyes under the operating microscope. We check the horizontal corneal diameter. We do a detailed fundus examination if the view is possible. Then if the view is not possible, we need to do a B-scan ultrasound examination to look out for retinal detachment, persistent filter vasculature, and retinal coloboma. We also do a cycloplegic refraction. Extensive investigations are not always required, especially in unilateral cataract or a known family history of cataract. Routine investigations for anesthetic and operative purposes are required. Other investigations are based on the history, the morphology of the cataract, and systemic association. For general investigations, we want to check the food blood counts to be sure the child is not having any underlying infection or anemia. We look at the electrolytes, urea, and creatinine to determine the renal function of the patient. We check the urinalysis for sugar. We can order for electrocardiography or chest X-ray. Specific investigations is determined by the associated conditions. We are suspecting touch, we will need to do serology screening for toxoplasmosis, rubella, cytomegalovirus. Others are venereal disease research laboratory tests for syphilis. Others include biochemical profile for glucose, calcium, and phosphate. We can also do erythrocytes exam analysis or computed tomography of the brain if indicated. Newer tests include genetic evaluation. In centers where these are available, this can be done, especially in patients with bilateral cataract. Collaboration with a pediatrician is very important for full systemic evaluation, assessment of fitness to undergo general anesthesia, investigations, and even in the follow-up of the patient. Therefore, a comprehensive history, ocular and systemic evaluation, in collaboration with parents and other healthcare providers are indispensable in attaining an optimal visual prognosis. Thank you.